And good afternoon, ladies and gentlemen. I'm Kiyotake Ichizuka from Showa University, Kanagawa Prefecture, next to Tokyo, Japan. And anyway, I'm very honored to have the opportunity to present you to my topics today. Today's my topic is second trimester anomaly scan using new technology. I believe that participants of ISUOG are familiar with second anomaly scan. So today's my topic is just refresh for you. Okay, I will provide you today's agenda, the current situation of the second trimester anomaly scan in Japan. Next, before performing the scan, at first, anatomical survey during the second trimester ISUOG guidelines and anomaly cases presentation. The current situation of the second trimester anomaly scan in Japan. I will show you the change in the number of births in Japan. In 2016, the number of births in Japan fell below 1 million for the first time. Since then, the trend of gradual decrease has continued. According to latest data, in 2022, the number of births fell below 800,000. Therefore, we need to perform 800,000 screening tests a year by limited medical resources, so we need to perform it efficiently. Second trimester anomaly scan in Japan. At first, all pregnant women should have a screening, but it is unideal in Japan. When we perform second trimester anomaly scan at between 18 to 20 weeks, pregnant women cannot be had the artificial abortion after 22 weeks of gestation by legal issue in Japan. Pregnant women have a second anomaly scan by 20 weeks of gestation to allow time for further tests such as CVS or amniocentesis and its results. And costs in Japan. Costs vary depending on the facility. It depends on the number of items checked during screening. More detailed screenings costs more. Guidelines in Japan. JSAM, Japan Society of Ultrasound Medicine, proposes guidelines for obstetric ultrasound specialists or those aiming to become specialists. On the other hand, JSOG, Japan Society of Obstetrics and Gynecology, proposed guidelines for all OB/GYN doctors as a minimum requirement screening. So, screening items of JSOG guideline is less than that of JSAM and ISOG guideline. JSAM guideline is similar to ISOG guideline. Next, I will present you before performing the scan. Who should have a mid-trimester fetal ultrasound scan? All pregnant women should be offered a mid-trimester scan as a part of routine prenatal care. When should the mid-trimester fetal ultrasound scan be performed? As I mentioned before, in Japan, we perform ultrasound scan between 18 to 20 weeks of gestation. It will take about 2 weeks for the results of further examinations to be known. A routine mid-trimester fetal ultrasound scan should be performed between 18 and 24 weeks of gestation, depending on technical consideration and local legislation. Who should perform the mid-trimester fetal ultrasound scan? Individuals who routinely perform obstetric scans should be trained in diagnostic obstetric ultrasound. Next, anatomical survey during the second trimester, ISUOG guidelines, and anomaly case presentation. I will show you a lot of images, so relax and listen to preparation for next year's sessions. Head part. We should check intracranial, head shape normal, cabium safety pericydium, choroid plexus, midline falx, thalami, lateral cerebral ventricle, cerebellum, cisterna magna, nuchal fold. A lot of items. This slide shows intracranial. This cranium is intact. This is head, ventricle, and choroid plexus is seen. In many cases, it is difficult to see the lateral ventricle as the near side of the transducer due to shadow of near side cranial bone. It is not clear. How about this image? You can see the near side lateral ventricle relatively clearly. Why can we see clearly? Please pay attention here. Please pay attention here. This is bone gap, post-lateral fontanelle. Ultrasound beam can pass through this bone gap. We should use this bone gap when we evaluate intracranial structure. When we observe the posterior fossa, we should tilt the probe against the ultrasound beam about 3 degrees against the horizontal line of the monitor, here and here. So we can get the window of fontanelle around here that pass the ultrasound beam as well as previously I mentioned before. We can see the posterior fossa clearly. And cisterna magna here may contain thin separations that are normal structures and should not be confused as normalities. This is normal. This is cerebellum and cisterna magna. Very clearly, this is cisterna magna and cerebellum. We can distinguish between cerebellum and cisterna magna very clearly. Next, I will show you some cases. What is this? It is easy. I think it is easy for you. This is choroidal plexus cyst, bilateral choroidal plexus cyst. Next, what condition does this fetus suffer from? This case is 18 weeks of gestation. What condition does this fetus? This is same one. This is a coronal section. The brain is not divided into 2 parts, single ventricle and fused thalami. This condition suggests trisomy 13. This fetus complicated by holoprosencephaly, a lobar type. Next, this image represents not only ventricular megaly, but also abnormal cranial shape. This is like a lemon thing. In addition, when we evaluate the ventricle, we pay attention both sides and the ventricular shape. Ventricular shape is very important. This ventricular shape is distinctive, you know. This ventricle is angular shape. These conditions suggest that its fetus is complicated by NTD, neural tube defect. If we find this situation, we must observe fetal supine very carefully. Next, this slide shows a thickened nuchal fold. This is thickened nuchal fold. This fetus was diagnosed with Noonan syndrome after birth, but it is difficult to diagnose before birth. Only this condition, only this condition. Next, I'll show you abnormality of the posterior fossa. This fetus is 14 weeks of gestation. It is too early as a second trimester scan. But what condition does fetus suffer from? This is pathological condition around here. This is orthogonal plane visualized 3D US. In sagittal view, centrium is going up, and axial plane, cerebellum vermis is missing, and hypoplastic of the cerebellum. So we diagnose this fetus to Walker anomaly. Next, face and neck. We should check both orbits and bulbi present, mid-sagittal fetal profile, nasal bone, upper lip, absence of masses. This is both orbits and the bulbi. You can see the orbit and the bulbi intact. This is intact fetus. And this is mid-sagittal facial profile. This is Japanese fetus, so it is low, maybe, rather than the European fetus. But this is normal in Japanese fetus. This is nasal bone is intact. We cannot doubt that this fetus is trisomy 21. It is normal. And this is upper lip. Upper lip is intact, and the nose, both intact. And I will show you some cases. How about this fetal profile? Is it normal or abnormal? This is Japanese fetus, 19 weeks of gestation. Even if it's in Japanese fetus, but this is pathological, abnormal facial profile. And this slide shows the upper lip here. This fetus is same as the previous slide, bilateral cleft lip. This fetus is complicated by trisomy 13, confirmed by amniocentesis. Next, what is this? This is axial view at the orbital level. At first glance, it looks like there are 4 eyes, but that is not true. This fetus is complicated by bilateral diagnostic bilateral, like 4 eyeball. This case is unilateral diagnostic. This is eyeball and unilateral diagnostic here. Almost of them will disappear during pregnancy or during fetal period. Diagnostic. Next, chest and heart. We should check chest and lungs, heart activity, 4-chamber view, aortic and pulmonary outflow, LVOT view, 3-base cell view, or 3-base trachea view, and no evidence of diaphragmatic hernia. This slide shows the chest and 4-chamber view. 4-chamber view, this is normal. And this slide shows measuring the cardiac axis and size. Measuring the size and axis of the heart is sometimes troublesome. Latest ultrasound diagnostic equipment automatically measures them. It is very convenient to us. This slide shows pulmonary vein. A pulmonary vein, this and this, into the left atrium very clearly. Not only main pulmonary artery vein, but also peripheral pulmonary vein we can see. Furthermore, using SMI, it is possible to examine the peripheral pulmonary vein and without large motion artifact. So SMI helps us. And this is a pulmonary vein into the left atrium very clearly without large motion artifact. And peripheral pulmonary vein is seen. This is for chamber view. This is intact septum, and we can see the left outlet here. And this is LOT. When we observe LOT, it is important to confirm the continuity from septum to ascending out. This continuity is important. This is ROT. This is a pulmonary artery. This diameter is larger than aortic, ascending out. This slide shows the three vessel view. This is pulmonary artery and ductal arch and aortic aorta and superior vena cava. This is very normal. This slide shows the three vessel trachea view visualized by luminance color Doppler. This color Doppler is very clearly. This is pulmonary vein, pulmonary artery, and aortic out to the descending out. This slide shows the aortic arch in sagittal view. Aortic arch have neck vessels, so we can distinguish between the aortic arch and ductal arch from this point. This is very clearly three neck vessels is seen. And this is aortic arch visualized by color Doppler. We can see the neck vessels originated from the aortic arch very clearly. This is color Doppler, typical color Doppler. We can distinguish three vessels. And this is ductal arch. Ductal arch originates from right ventricle, and ductal arch does not have neck vessels. So we can distinguish between ductal arch and aortic arch from this point. Next, abdomen. Stomach in normal position, and bowel normal, and gallbladder, both kidney, urinary bladder, cord insertion site into the fetal abdomen. At first, we have to confirm the fetal laterality. It is mandatory issue. After we confirm the fetal laterality, we check the stomach at the fetal left side. This is normal. This is cord insertion site into the fetal abdomen. Here, this is normal fetus. This is urinary bladder and umbilical artery. Umbilical artery can be seen on both sides of bladder. If you can observe an umbilical artery, it means single umbilical artery. I will show you some cases. What is this? I think it is easy to understand for you. This is Onfalcil, 20 weeks gestation. This slide shows a hyperechogenic bowel. Echogenicity is similar to the bone. This is a case of hyperechogenic bowel. Hyperechogenic bowel is considered to be a kind of soft marker of trisomy 21 in the second trimester. And this is periectasis case. At 20 weeks of gestation, periectasis is diagnosed if anterior-posterior diameter is 4 mm or more, here and here. By the way, this slide shows the measuring the dilated renal pelvis at an axial view. But is this correct? Do you think? How about this? Since the level indicating the maximum diameter is different for the left and right, so it is impossible to measure in one axial section. So this is incorrect. Periectasis case. By using 3D echo, it is possible to give images objectivity. So we should measure the right pelvic, renal pelvic at this level, and left, we should measure left renal pelvic at this level. So it is possible to give images objectivity. So this is very useful. This is same case, visualized by 3D rendering mode. When we explain the such condition for the patient, this model is very, very useful and make patient to be easy to understand. This is rendering mode very clearly. Next, skeletal. No spinal defect, arms and hands present, legs and left feet present. This slide shows normal spine, like a double rail sign, and skin intact. I will show you some cases. What is this? No cyst around here, but continuity of the skin is interrupted around here. So we diagnose this case myeloschisis. Myeloschisis visualized by 3D US. This slide shows a defect of skin very clearly right here. No cyst. Next, placenta and umbilical cord. Placenta position and relation to cervix. No mass present. 3-vessel cord. Cord insertion to placenta, normal. This is SMI cord insertion. When we diagnose cord insertion site, we can diagnose it using only B mode, maybe. However, we use SMI mode, it becomes too easy to detect the cord insertion. And SMI mode can detect the intraplacental vessel, such as stem villi, and further peripheral vessel, villi vessel here, very clearly. And this is cord insertion site here. So SMI helps us. By the way, have I checked all screening items? We have to check a lot of items, so it takes a lot of time. We should avoid to waste time. We check the items that is easy to obtain regardless of the order. However, so do, you may forget the items that is must be checked. New function, new technology make us prevent this situation. Therefore, I would like to introduce the protocol assistant implemented in ultrasound diagnostic equipment such as Apulio. Problem lists appear this area, and problem list appear the left side, and reference image appear too. So this reference image help us during screening. Once an image has been saved, it will be marked with a check mark. This image will be stored in order according to the protocol. Once the final item has been marked with a check mark, the system will automatically return to any unmarked items to complete the protocol. And confirmation dialogues are displayed when protocols are interrupted or terminated. And it is impossible to change to alternate protocols. For example, cardiac scan or fast scan during the examination. So this tool is very convenient for us. So this is my last slide, take-home message. Screening scan can be performed systematically and in accordance with a checklist to prevent omissions. These are some conditions for which 3D-US is useful for diagnosis. Use useful assistant tools for screening to prevent omissions. Thank you for your attention.
Thank you very much for your kind presentation.
Thank you very much.
Well. Thank you very much. Are there any questions from your side? Anybody has a question to ask?
Thank you for presentation. I have a question. How long does the examination take?
Second trimester scan?
Yeah.
Yes. Up to the physician scan, but in our situation, we have 30 minutes in the patient. But in common, it takes about 15 to 20 minutes, maybe. But up to the skills, screener skills. Thank you.
If you have found abnormalities, included the time, 30 minutes?
No.
No.
No. If we find the abnormal findings, screener will refer to a specialist at the next time. Yes.
Thank you very much.
Any other question from the audience? If there are no further questions, I'd like to thank you very much.
Thank you very much.
And I think especially these supporting tools will help you and all the people in the audience in the future
I think so.
further than they do today.
I think so.
And it will be very interesting to see what's coming in the future with you.
I think so. Thank you very much.